Hello, everyone. I think there are still a few more people joining us in the Zoom room, but just want to welcome you all this afternoon. I'm Emily Rowland, Senior Director of Program Implementation with Carinova and the North Carolina Healthcare Foundation. And I am pleased to welcome you to our It Takes a Conversation virtual town hall today. Our program is on reimagining rural health, and it's part of a series of town halls that connect North Carolinians with hospital and health system leaders and other healthcare stakeholders. These candid conversations will highlight the challenges, successes, and future for healthcare in our state. A few housekeeping items: all lines will be muted throughout the program. If you have any technical issues during the webinar, please send a note in the question pane and we will assist you. Questions may be asked anytime by clicking the Q&A icon at the bottom of your screen. And we have a full schedule, but hope to be able to answer as many questions as possible. And now I will introduce you to our moderator and panelists for this virtual town hall event. First, Michelle Fortune, CEO at St. Luke's Hospital, will serve as our moderator today. Thank you, Michelle. We also welcome our panelist, Kathy Bailey, President and CEO at UNC Health Blue Ridge, Brian Floyd, President at ECU Health Medical Center and COO at ECU Health, Linda Stanley, President and CEO at Dosher Memorial Hospital, and Jesse Tucker, President and CEO at UNC Health Wayne. Thank you all so much for joining us. And Michelle, I will turn it over to you.
All right, wonderful. Good afternoon, everyone. In North Carolina's 80 rural counties, health systems and hospitals provide access to care close to home. We advance innovation, we invest new resources in our communities. These hospitals do much more than just provide healthcare services inside their walls. They are part of the communities and they collaborate to address social determinants affecting health, like food insecurity, transportation access, and many other societal issues. Today, we're going to talk about some of the challenges that rural hospitals face, as well as the opportunities ahead to continue improving rural healthcare in our state. I'm so excited to have these panelists. I know many of them so well, and they're going to share some really innovative things that they're doing with you today. As I said, hospitals are a lot more than just healthcare. They are the economic anchors in the communities they serve, especially in these rural areas. So we'll start with our panel today discussing what role do hospitals play in rural communities and how does this differ from hospitals in urban settings? So Jesse, why don't you start us off?
Yes, ma'am. Thank you, Michelle, and thank you all for the opportunity to serve on this distinguished panel of leaders from around our state. To the question of economic impact, of course, our hospitals are often the lifeblood of our communities. We serve as the anchor, and right here in Goldsboro, for example, or in Wayne County, rather, we are the third largest employer next to agriculture and our Air Force Base that's here. So many of our decisions, impact the community in terms of being able to grow, being able to attract larger employers and improve the situation for many of our members in our communities to be able to improve their employment situation. So I think that's where we really play a significant role to attract employers to the community.
I think Dozier is a little different than most of the other organizations that are here, and that's because we're tax supported by our community. So not only as a healthcare facility are we expected to support our community, but they pretty much demand that we support our community. And it may be something as simple as attending an event, going to the churches, serving on boards, but they really do expect us to be a part of the community, not only to provide health care to the community.
Great point, Linda. I experienced that here in my own county as well. Anyone else?
I would say at ECU Health, we are part of a system of care, all rural communities. So all of our hospitals are located in tier 1 economic environments where there's a lot of socioeconomic distress and issues. And really, beyond the healthcare that we provide, especially as an academic, medical center organization, we're training people, and that reaches beyond the next year's workforce. It's also about how you take tier 1 poverty community and take first generation education to the next level. and the next level. So we see ourselves lifting people from a situation where actually the work we do as a healthcare system is driving future economic growth into homes, but more importantly, education and often hope, because we're bringing people out of a poverty situation and teaching them how to be productive and how to do something that gives back to your community and the rest of the world around us. And so I think the role that hospitals play and the healthcare systems play, especially in rural communities, is incredibly important to the future families, generation after generation in those areas.
Absolutely. I know each of your hospitals and health systems provide enormous amounts of community benefit each year. And Brian, to your comments about, lifting individuals, let's talk a little bit about the recent North Carolina bill that was passed to expand Medicaid. That's going to provide health care to over 600,000 people in our state who are currently in the coverage gap. Can one of you or more of you talk about why this landmark legislation is so important, especially in rural communities, considering all that we just talked about?
I think one thing that we're looking at in our community is obviously there is, as you said, the huge gap. In our communities, we've got 2 emergency departments, we've got 5 urgent care, express cares, 45 plus physician practices, but there's still the gap because there are people that can't afford to receive care in those areas. I think Medicaid expansion will go a long way toward families being able to go to the doctor, go to the urgent care, seek care where it's appropriate, and then be able to pay for it.
Absolutely. Anybody else want to share your thoughts on this legislation? I know we have celebrated it as a group. The reduction in this uncompensated care is going to have a particularly heavy impact on struggling rural hospitals. And I know facilities like ours, that is a small 25-bed critical access hospital. This was a celebration in care and also to help us as we struggle to try to serve those that can't pay for care. Anything else anybody wants to add about that?
Yeah, I think, to Brian's point of, lifting families out of poverty and providing hope, I think this gives us an opportunity to, from an emergency management perspective, stop filling sandbags and start building foundations. So
Great way to put it, Jesse.
I think that gives us an opportunity to do that. Oh, yes.
What a great way to put it. Well, I think you all alluded to the barriers that are unique sometimes for residents in rural community to getting health care, things like poverty, access to care. Unlike our urban counterparts, people may have to drive much farther to get the care. There is a lack of availability of healthy food sometimes in these rural areas that don't have as many transportation options as our metro counterparts. We know if those items are left unaddressed, the barriers can lead to chronic disease and other health complications. How does your hospital combat these barriers to ensure your community has access to resources that they need?
I'll start with that with Dozier, and I'd like to reference the Brunswick Wellness Coalition. We started our work really about 2015 as a result of a grant we received from the Duke Endowment. And I will say that when we started this work, Brunswick County was number 36 as it related to health outcomes in the state. And our goal was to, of course, improve the health of our county. We just received the most recent rating and we're number 25 now. So we've made some huge steps working through this wellness coalition, using some of the initiatives such as access to care, addressing disease, diabetes, food insecurity, looking at community gardens, a lot of work in community gardens, farm to school, just to name a few of the initiatives that we've used in order to help move the needle, again, moving from number 36 to 25 in that period of time. So we're really proud of the work we're doing in our county to address and working as a system within our county.
What incredible work that is. I know, Brian.
I think you froze, Michelle, so I'll just jump in since you called my name. The the work that we talked about, if I can connect Jesse and Linda's response to that, going back to the issue that's particularly in rural communities, health conditions are so connected to the socioeconomic condition of a community. And when you think about our historical way we take care of patients by saying you need to see your doctor, you need to take these medications, and pushing a care model on our patients, that goes as far as their ability to afford that. And what's worse than not being able to afford it is it seems unattainable. And so then you just disconnect from health altogether. And you say, I'm going to make choices to live my best life in the moment and not necessarily look at the overall health condition. So the partnerships like Linda mentioned, where you're thinking about community gardens as an example, we've had a very successful venture with at least 2 very underserved communities, where through one at a local church environment, where there are now 70 some lay health coaches that have been trained in community college, all of whom are children, by the way, who are helping their own homes and their own grandparents and moms stay disciplined to the medication management, reach out for help when they can't, more importantly, tend and be part of the community garden. And it has been transformational for the cost of care in those communities. And if you talk to Reverend Joyner, who leads that particular initiative with us, he'll tell you the biggest outcome has been hope in an otherwise hopelessness situation in some of these homes. We recently created a community garden at one of our hospitals, one of our rural hospitals in Little Washington, North Carolina, at Beaufort Hospital. They have a garden. They call it not a garden. They call it an outside classroom. And its intention is to open its doors to the public, who can come and partake from the produce right there at the garden. But when they do, there are dietitians and nutritionists that talk about, let's talk about the recipe with which you're going to use this. And you're welcome to this food as much as you like. When we do, every time it gives us a chance to interact with them about food choices. And what we find often when we're having that interaction on a bare necessity of food and their interest to be able to improve their health outcome that way, we also get a chance to interact on other issues that are common to chronic disease patients in socioeconomic conditions. So it's a great way not only to meet a food insecurity need, it's a great way also to meet the needs of people who don't exactly know how to reach out, perhaps, or who feel that it has just become beyond them to take the steps toward their health. And so those are just great partnerships. I know a lot of us have these community gardens, and their biggest issue is the socialization that happens when people come together around food.
Yeah, I think the hope that you're talking about is so huge for the community. Kathy, were you going to share?
Yeah, I was going to say we have a little different twist on that. We partnered with the public school system, and we sponsored a mobile food truck that goes out, especially in the summertime, to neighborhoods where children do not have access to healthy lunches, and they're taught how to make healthy choices. We also sent out dental care kits and did education around appropriate dental care, and then send out different health information pamphlets through our educators. You know, they may not be in school in the summer, but we still are participating with them learning and with their food insecurity.
It's amazing work. And I think sometimes people don't automatically associate this kind of work with hospitals and health systems. Let's talk a little bit. Those things are part of the reason why it's so important that we protect these rural organizations. I know you all know that since 2005, more than 180 rural hospitals have closed across the United States, according to the SHIP Center. And we all know, leading these organizations, that when hospitals close in rural areas, it makes it more difficult for the community itself to thrive. Why do you think the survival of rural hospitals is so vital to the community, and what can be done to keep the doors open?
I think we said earlier, when Jesse started it off, we are the economic pillars for so many of our communities. We're the largest employer, usually, or at least within the top 2 or 3 largest employers. And it's about bringing people into our facilities, educating them about proper health care, about healthy habits, providing a place for them to work, and then seeing the families continue to grow. I mean, most rural hospitals, you have generations of family working in the facility. And we enjoy seeing that. We enjoy growing our own. You get the first person in through the different programs at the school, and then they get into a healthcare job, and then you see the next generation come along as we help them.
Kathy, I love that you talked about education, because I think every person listening to this panel right now should be an ambassador for the importance of rural healthcare, and us educating our communities and legislators and the next generation about why this work is so meaningful and why it matters is so important. Let's talk a little bit about how that ties to perhaps recruiting and retaining the best and the brightest. We know that having a strong quality workforce in rural areas is essential, especially at a time when hospitals nationwide are critically short-staffed. How can we inspire students to join the healthcare field and focus their career on working in rural areas? And how can we better recruit specialists and primary care doctors across the state? Let's talk a little bit about how we do that. What are the unique things that your organizations are focusing on?
I think we can all say that it's important that we grow our own. We've been in this environment now for the last 3 years in particular, where it's been very challenging to acquire healthcare providers. So a couple of things. One, grow your own. So therefore, we need to start early, get in the high schools, get in the middle schools, and get those students engaged in healthcare to understand what role they can play in healthcare. Many times we go to the community colleges also, and we look for nursing. Everybody you go to the community college for nursing so that you can be used as a clinical site in particular. But we've gone a step further, and we're looking at interns for things such as biomed, IT, dietary. So I think we need to look beyond that nursing scope or that bedside scope, but look across the organization, which will give an additional opportunity for our community members to be engaged in healthcare. So that's one of the things that I think is going to be important to our survival. And of course, recruitment, use every resource we can find, whether it's through the rural health grants that are available or the health service corps. All of those resources, we need to certainly make sure we're tapping them in order to help us.
Yeah.
We started an initiative called NC STEM East, and it's a partnership among schools, colleges, and local communities to really get under the hood of this, what Linda just talked about, this idea of growing your own. Communities are going to have to help revitalize their local hospital and not just rely on the hospital to revitalize the community. And that's gotten lost over the years. Hill-Burton Acts funded many of these rural community hospitals. They were never sustainable capital investments to begin with, without state and federal partnerships to put those dollars in place to build those community hospitals. So we would be foolish to assume that they can just thrive in the absence of more invested interest of the local communities. And so what we're focusing on is, as we all know, is that workforce of the future is the actual most important investments we're all going to make right now in both the future of our health systems, but also overcoming the challenges financially that health systems and hospitals are facing. Medicaid expansion is great and it helps, and it'll do a lot to bolster our local economies, but overcoming the workforce gap is essential. I happen to be in a system with 9 community hospitals, and one of those is a 1,000-bed hospital, but it's all rural. So you can imagine the tremendous challenge of finding 4,000 nurses to run a rural region's hospital system, right? That doesn't happen without going, just like Kathy and Linda have talked about, going right to the front line of where students become interested in their future. And what we've chosen through this initiative is to be a convener of the discussion to teach local schools what healthcare is like. So those teachers in those rooms understand our need, understand the vital role that a teacher in a school, in elementary or high school even, plays in helping their local health system be vital 4 and 5 years from now. And when they understand who we are and they understand the unique challenge, then they start to believe our mission is their mission as well. They can contribute to something as important as the health and well-being of a region by inspiring 1, 2, 5 children right in their classrooms to want to be the people that carry us forward into the future. And the more they know about that, the more they actually are able to interest the student. It's not like you can be a nurse. It's that they understand what a nurse means, or what a pharmacist means, or what a biomedical engineer means to delivering care in their community. And it's a very different conversation then about why they are engaged in this work alongside us, because they have accepted that mission to help bolster their local health systems. And it's going to take that kind of work to overcome a pipeline problem that North Carolina has a significant challenge when you look at workforce numbers into the future. It will take really a renovation of trying to get people interested in healthcare early in the elementary school systems forward, and then helping make sure we have student success in rural communities specifically, because we have to grow our own for those rural communities, not just a big pool of people that can go anywhere in the nation. We need the people in those communities to want to be in those communities and serve those communities through their local hospitals. So nothing works better. Trying to move people from urban environments into those rural environments can be very challenging. But the student that grow up in that community is the best, most likely candidate to help fill those gaps in the future. So we're investing in grant programs to help school teachers understand us better, and have local counselors in the schools to help these students both succeed academically and be interested in what we're doing. And then, of course, there's the volunteering programs you bring students into your hospitals to learn through that are really important.
I think for sure, the investment that we all have to make in starting earlier and building a passion for individuals in the community and students and children for caring for others and showing them the connection to purpose of the work is important. I know, Kathy, your organization has done some really unique work in that area as well. You want to share anything about that?
Talking about the graduate medical education, or?
Yeah, and the Camp Med, the Blue Ridge Scholar Program. I know you've done a lot of work in that space.
We have, and we do a lot. We started in the elementary, middle schools. We have Camp Med for middle school. We have the Scholar Program for the high school students. They actually spend a summer working with us on different projects. They actually get credit through the school for this work. Take it beyond that, though, into our graduate medical education program. We partner with Campbell University School of Medicine. We have medical students here. And then we have internal medicine residency. We have a gastroenterology fellowship and a gerontology fellowship. So we're training physicians in a rural setting, hoping that they will stay in a rural setting once they finish their work. We retain about 20% of the residents and fellows that come through our program. Most of the time they go off to the larger urban centers, and that's where they train. And it's hard, as Brian was saying, it's hard to get them from an urban setting into a rural setting. So we feel if we can train them in a rural setting, we have a better chance of keeping them there.
I think, Kathy, that's so true, because if they can experience in their residency working in a rural community, they're much more likely to either stay there, or if they go away for a while, to hopefully come back later. I know we've had some experiences with recruiting specialists to our rural area, and we've really done that through community and showing them what a wonderful lifestyle it is and how close they can be to the care that they're giving. And I think that resonates for a lot of providers who really want to make a life's work out of service in their calling. And so I think that's important. The other thing that I think, go ahead.
Joe, you mentioned something there that I would want to reassure the 191 people that are on the call with us today. We talk about rurality, and sometimes we describe it in ways that feel like there's just a bigger barrier to overcome. Brody School of Medicine, of course, was created to train primary care physicians for the state, and largely designed to help keep them in rural communities. But we did a lot of what Kathy's talking about. We started an actual rural residency program as an extension of that medical school and added slots. And I thought, well, people aren't going into rural healthcare these days. The truth of the matter is we have a line of people applying for the rural residency slots, particularly because they already know going into it. They want to learn all they can, and they want to go give back where it's needed most. And you're not going to find places that need it more than our rural communities do. So actually, the good news for everyone is people are interested in doing this work.
Absolutely, absolutely. I mean, in the past year here, we've recruited some wonderful specialists from large urban organizations who wanted to come give back. And I think you're right. If you can show them there's a desire for innovation and collaboration and a true connection to care, it really sparks an excitement in these providers. So maybe let's shift to talk about that. It's my personal belief that these rural areas are innovation engines that, you know, sometimes are overlooked, that people don't always think about us as the best place to innovate to improve care, when in reality, sometimes we would be so much more an ideal location than an urban counterpart to try new things. Cutting edge solutions like telemedicine and virtual visits are particularly impactful in our areas where it can be more difficult to access. So can you all talk a little bit about what innovations your hospitals are using to provide care in hard to reach communities? Because there's some great innovative work going on in that space.
I'll start by talking about our virtual hospital through COVID. You know, we had talked about virtual visits early on before COVID hit, and our medical staff was a little resistant to it. Oh, we don't need to do that. Well, when COVID hit, we knew that we could not handle all the COVID patients in the hospital and have room to take care of the truly critically ill patients. So one of our primary care physicians stepped up to the forefront, and 8 days from concept to implementation, we had a virtual hospital up and going. It was extremely successful. From 2020 to 22, we took care of over 12,000 patients virtually in their homes, which allowed us to keep the hospital beds free for the more critically ill that did need to be inside the four walls of a hospital. If we had been a large urban center, I don't know that we could have taken that idea to implementation in 8 days.
We're nimble. We're nimble, right? The
Yes.
smaller rural locations are nimble.
Yes.
Great example.
Oh, yes.
Great example.
A unique example here in Wayne County, we have a program called Watch that's unique in its perspective because it's funded by the hospital, Duke Endowment, Reynolds Charitable Trust, I think the state. We get some funds from Blue Cross Blue Shield of North Carolina, the Golden Leaf Foundation, the city and the county, and we all come together to create 3 different sites. One of them is completely mobile. It's actually a reconfigured bus that's actually a clinic. It has 2 treatment rooms in it. Does some point of care testing and things like that. And that unit actually travels to parts of the county that are grossly underserved, and it's only for uninsured patients. So these are for only for the uninsured. And so this van is able to, really a bus is able to go anywhere in the county that we need for it to go. And of course, during the pandemic, it really helped out for a lot of the communities that were hardest hit and did not have transportation and couldn't get out. We also have 2 other sites, one where we partner with the YMCA, where they also offer some education classes and some fitness classes for some of our most challenged patients. And then we have another site here at the hospital to help with some of our ED visits that are inappropriate for the emergency department, but they don't have access to primary care, and so they can visit that site. So those are 3 locations, one that's of course mobile and moves around quite frequently, that we're able to provide here through a very collaborative effort, and we're very happy of the results that we're getting from that work. And we hope in the future with Medicaid expansion that that unit can actually help us help us with enrollment as well. So, and with education in the community.
That's wonderful. Wonderful.
I think I think what we can all say is that at the end of the day, COVID taught us a lot.
Absolutely.
It showed us what we really can do under pressure. And I think that's something we don't want to forget as we move forward. One of the things that we did during that period of time was to go to with the grant support, go to minority churches within our community and set up telehealth. And that opportunity not only allows those people to go to a safe space and have their telehealth visit with their physician, but we also provide education through that same system. And so that is something that I think has really been very beneficial to help with transportation needs. Again, it's a safe space. We not only provided the equipment, but the training so that they would know how to use that technology. So as a result of the Fill the Gap grant, that was an opportunity for us to get into minority communities and provide that resource for them.
Well, you all have given a number of examples and referenced, COVID, and you've referenced other community entities and partnerships. So maybe let's talk just a moment about how beneficial it is to collaborate with other healthcare partners and entities. I know from some of the examples you've just shared that it expands your hospital's reach within the community and it helps patients access specialized care. Is there anything else you all would like to share about approaches that you've taken to these partnerships during COVID and beyond that have really created an access to affordable care close to home?
Yeah, absolutely. I'll start us off, Michelle. One of the things that's unique about the UNC healthcare system, and Kathy can attest to this too, we are somewhat of a loose federation in a way that we're not owned, we're managed hospitals in some respect. And so we have a lot of opportunity, I think, to try out a number of different things that may not be functional in a quote unquote traditional system. But one thing I will say that has really helped us as we've rebranded around the state and many of our facilities, it's also helped us to make that connection stronger through things like tele-ID, EICU, and telepsych and telemedicine offerings. We've got teleneuro as well. We always had telestroke, of course, but we've been able to expand that quite a bit. And back to something that Kathy said, that has even helped us to attract physicians to the area. Of course, we're not an ACGME site and we don't really have formal training programs, but as Kathy mentioned, we have Campbell students here as well. And that long game, if you will, is to get them to come back when they finish their training. We've had 2 to come back after they finish their training. And one of them had commented on the interesting telehealth offerings that we have here and allow us to take care of patients and keep them, as we say here in Goldsboro, close to home. The final thing I'd like to mention is that we've gotten approval for a hospital at home waiver. We have not actually implemented that yet. And so following with our mothership Rex Hospital in the Triangle, they have a very vibrant program. So we're trying to see if that will work for us in a rural community. And so we've got transport vehicles, we've got paramedics and some APPs that will help do home visits. And we're going to see how that works going out into the future. But we would not be able to do that without support from the system that has the latitude to, I guess, create that think tank for us to where we can take on these innovative challenges and opportunities.
Well, you've given some great examples, all of you. I do want to move us to some audience questions. I know that we have folks on this town hall panel today that have questions, and we have a few that were pre-submitted. So let me start with a question. This came from Brian from Raleigh, North Carolina. And Brian asked, how do your hospitals and health systems plan to expand access to mental health services? And how is telehealth a part of that strategy? So if the panel would talk about that a bit.
I'm happy to start. We have a program called NC Steps that actually was born out of ECU a few years back. Dr. Sai Said and his team that now become a statewide tele-access to behavioral health services. It's been shown to be very beneficial. There's a readmission reduction. There's clearly an ED reduction, but it was largely built to piggyback on ED visits that were already occurring. We learned something in the process of both COVID and then, as you mentioned, as this telepsychiatry is rolled out, is there are so many other disciplines not defined as tele or behavioral health services where you really need to get to these patients. And a great example would be mothers in perinatal care. And we have piggybacked the program called Mothers. There's grant funding for these things that were brought into the table to help us with high-risk pregnancies in very rural, underserved communities where they don't have often access to immediate OBGYN services. And we piggyback the telepsychiatry program. And what it's doing is bringing more, as you know, the primary care hub to high-risk environments where there is critical need. And it expands both behavioral health. It can also be used to connect to the OBGYN in rural communities and certainly other services as well, as we all know that they're interconnected together. So I think on that, we then decided, now how do we use our primary care homes? We have 120 clinics located in rural communities. How do we bring behavioral health services through telehealth into those clinics? And so imagine that our primary care homes also include those specialty consultation services through telemedicine in every location that we have primary care. That's how we're starting to expand access. We envision that also working with our faith-based partners where telehealth can be available in communities where people, I love what Linda said, they go where they trust and where they have support systems around them. No one's supporting them more than their family, friends, and that are right there bringing them to church. So let's use that environment where it's safe, where there's healing and hope, and let's bring services of specialization such as behavioral health services to those areas and use telehealth to reach patients where they already are.
Absolutely. Anybody else want to share anything about behavioral health and telehealth? I know it is something that this group and many others across the state spend a large amount of time focusing on.
Oh, yes, we have significant challenges, as I'm sure everyone does, in terms of recruiting to our area. So we actually moved largely to telepsych on the inpatient side, and that has been just a significant game changer for us, especially in the ED and on the floors, but largely in our emergency department. So that's really helped us to provide care for patients that otherwise we would be challenged to care for.
I think teleservices have made such a positive impact on many of our organizations. Let's move to a question. This comes.
Michelle, can I just make one comment before we move?
Please.
And I just don't want to leave this topic without saying that we all use telepsych, we all use telehealth, but at the end of the day, that may not be the answer for some of our community, and we need access to care, inpatient care for those patients, which is a real challenge across the state. So I just can't leave that topic without making that comment.
I think that's a wonderful addition. It's such a challenge because there is not enough inpatient care. And so I think an important note to make, Linda, thank you for doing that. Let's move to a question from Gail. Gail's from Raleigh, North Carolina, and asks, how do you get information from the communities you serve about their needs, perspectives, and solutions to problems?
I'll just speak to that briefly. Something that, again, was born out of COVID/Brunswick Wellness Coalition is that in Brunswick County, when you put together our health department and our hospitals, we're able to leverage the work that we all do individually. And as a result of that, we came together this year and did the very first community health needs assessment together as a county. So I think that's really going to be beneficial, and I'm hopeful that it is going to really, the county will reap the benefits of us working together, identifying what the true needs are, because we did the surveys, we've heard from the entire county, and now we can determine where we're best suited to have the greatest impact, but yet impacting the county as a whole. So for us, that's how we heard from the county through our community health needs assessment, and that's how we're going to address it countywide with all of the 3 entities at the table.
Very important work to do those community health needs assessments. Anybody else on the panel want to share how you really connect and hear the voices of your community?
I will, happy to go. In Eastern North Carolina, there's about 29 counties that are in that eastern belt, if you will. So obviously where we have hospitals, we have community health needs assessment, and that used to be done in a fragmented fashion, each county. Last year, or actually a couple of years ago, we started doing our community health needs assessment as a region and see if the information rolls up in a way that there's a compelling enough investment to be made that might mean more than solving one problem here, one problem there in each of these counties disparately. And it tells a story of what's most important. And there's common links, as you can imagine, to all of that. And so when you see the numbers roll up and you see the needs rather roll up, you start to say what we really need to do in the region becomes X, Y, and Z. And things like access to behavioral health is a great example. They push us to make strategic decisions like building a freestanding behavioral health hospital. Things like that do come when you look at the needs of such a large number. And so I think it gets to the issue that all of us participate in, and that's collaboration with each other to understand the needs of regions, not just in our particular environment, but how might we partner together to put some more systemic solutions in place to help particularly rural and underserved communities.
So I think we've got a really interesting question that kind of ties into what you all have been talking about with really connecting in the community. And this question comes from Amanda from Greensboro, North Carolina. And Amanda says, what have been your most successful strategies for enrolling your communities in health and wellness initiatives? So once you hear their voices and you're doing all this work, how do you get them to enroll and participate? Has anybody had successes in that area?
Well, one of the things that we've done here at Blue Ridge is partnered with our county and partnered with different businesses to do their employee clinics at their business. And through that, we address a lot of the health and wellness. One of our most recent initiatives is we had a wellness center on our campus, and we've just partnered with the YMCA. So the Y has now come in and runs that wellness center, and they're bringing those community programs, especially around youth, that we did not offer. So that's filling a gap within our community.
We have something similar in Goldsboro to what Kathy just mentioned as well. We have corporate health nurses that are out in many of our large industries, do flu shots and wellness checks, things like that. But we also try to get out to, as you know, as Linda mentioned, out to the fair and other locations. And we tried something very interesting where we had a virtual site where that didn't quite work out as well as we thought it would. So we're just trying different things to see what will connect with our community and what resonates with them.
So I think, Jesse, you make a great example. Not everything we try may work, but we've got to try those things to get out to our community. And again, I think the nimble efforts that we're able to initiate being in these communities and collaborating so closely with other organizations is a benefit. Anything anyone else wants to share on successes with enrolling your communities in those health and wellness initiatives?
I'll just also add that wellness starts at home. So we started with an employee wellness program. And it's important that then the employees are ambassadors to the community with what the challenges are and the initiatives are that we have within our walls with our own community of employees. So that's where we started. We're doing some really good work there. And I think that's important for the community to see. We established a walking trail so that the staff is out walking and we're encouraging others to walk. And then we moved again to our patient population, and we're really pushing for annual wellness visits, which gives them a preventive medicine plan. And so we're making phone calls. We've got all kinds of campaigns going on there in order to get our patients in so that they understand that their role in having great health beyond all the other things that we've talked about here.
What a great example when you talk about wellness begins at home and it starts with us. You know, if we keep our healthcare providers healthy and ourselves healthy and we model that behavior, that's so important. So thank you for sharing that. You are right. As already said a couple times, we are top 1, 2, or 3 employers in our communities. And so it makes a huge impact when we are setting the tone. Another question from the participants. John from Columbus, North Carolina asks, how can rural healthcare systems innovate for better patient care? I know we've already talked about some of the innovations that you all have done, but John also asks, what are the obstacles? And what are you seeing are the obstacles for innovation, and how do you think we can overcome those for future innovations in our systems?
I think I guess it's not really financial. It's not really, I think even structural. It's just the fear of failure. I think we know that we have very thin margins. We know we have very thin degrees of freedom and opportunity for error, if you will. And so we want to make sure that we're not making a decision that that could cause harm. And I think that sometimes paralyzes us from becoming innovative, because we want to make sure that we have measured 4 times and cut once. So I think it's something that we
You see,
all,
that's such a great point. You know, the margins are so much thinner at a small organization, and you got to be able to take these risks and try things, but you've got to really think it through. So well said. What else would the group share?
I think there's a structural challenge to this that just goes right to the heart of we know how to do healthcare, we think. And so we've designed operating procedures and health record systems that are meant to create interoperability among ourselves to be more efficient, to be more effective. And so then you get to this, how do you have the bandwidth to go outside of those lines you just created? How do you, why would you go outside of those lines when you're trying to standardize and trying to create efficiencies within the healthcare system? And so one of the barriers is that issue. And one of the opportunities that creates is to look beyond ourselves and recognize that there are so many other parts of societies that have the capability to help motivate certain behaviors, to help motivate certain support systems around patients that we are not designed to do always. We're designed to do a certain thing, and we try to innovate ourselves for the entire continuum, and that takes time, and that takes a long time. And sometimes our path to interoperability or efficiencies are in the way of that. So that when that happens and we're overwhelmed and don't have the bandwidth for the extra innovation, it's about letting others innovate and sponsoring them and helping come alongside and say, how can this be complementary? What you have the capability to do, how is that complementary to who we are and what we have the capability to support? And then collaborate towards solutions. And you'd be amazed what, as we talked about with COVID, you know, COVID taught us things, but it didn't teach us something we didn't know about necessity being the mother of invention. And in rural communities, there's necessity for invention to get access to care. And so that's why I do think our rural communities are excellent pilot program spots for really innovating. But if we leave it all to ourselves and we think that hospitals will innovate for the care models of the future alone, we'll limit ourselves. We don't have so much bandwidth, we don't have so much margin, and we don't have so much capability. But if you talk about behavioral motivations as an example, who better than churches that modify behaviors every day? That's what they do. And they provide support systems around. So what if the highest risk groups are really well connected there? And we focus some attention on how they can be part of our system. There's a lot to be done through collaboration, and the spirit of collaboration is something we all have the bandwidth to create in our communities.
I think you all have brought up so many great themes in the conversation so far today. You know, we need each other, and we have to be connected. And like you said, that really was certainly highlighted even more in the midst of a global pandemic, but it's lived every day in these rural communities, which sort of leads me to a final question that I'd like to pose to each of you to answer. And that is, what led you to go into healthcare? And more specifically, why did you choose to serve in a rural community? Certainly, I can sense your passion, not only on this virtual town hall, but also when I work with you regularly and I hear the work that you're doing. So why don't we have Linda start us off? Why did you choose to go into healthcare, and why a rural community?
I grew up in a rural community, so I'm very comfortable in rural. I'm not a city girl. So it worked well for me to, even though I went away to college, but to come back to a rural community to serve. And that's important to me. It's important that I'm able to serve. I'm in a role where I'm able to serve. And it's also important where I'm able to have an impact on the work and see that impact on the work that I do. So that's kind of what brought me to healthcare. I had a mentor from high school who was in healthcare. She encouraged me. I knew I was not bedside nursing material, but I knew I wanted to be in healthcare. And I started as a medical technologist, so I learned the clinical side. But again, at the end of the day, it's when I leave every day to come to work or to go home, it was what difference did I make in the lives of others. And that's what drives me and to come to work every day.
Beautiful, beautiful. Kathy, how about you?
It'd be a much better story if there was this big defining moment that said, this is what made me want to go into healthcare. But I grew up just knowing I was always going to be a nurse. And that's where I started my career, was as a nurse at the bedside. And I worked in large, very large academic medical centers. But I found when I went to rural facilities that I was truly living what we say here at Blue Ridge, and that is that we are friends and neighbors taking care of friends and neighbors.
Yeah.
You know, the people I see in these walls are the same people I see at the grocery store, or at the restaurant, or in church. And it makes a huge difference, because it really brings home the community aspect of rural healthcare.
You're not anonymous in a rural community.
No, you're not.
So a great way to say it. Brian, how about you?
I think that we all share a similar story if we're doing healthcare. Normally, we have this, I had the same sense of, I like to think about it, not just when I go home at night, but when I tell my kids what I spent my life doing. And at the end of my life, and I want to look back and say, what did I do with the brief time God gave me on the planet? Did I make a difference with that time? And I can't find anything that actually has more use for that, if that's what you're trying to do, than the work that we do. Not just because we save a life, but as we've talked about here today, from community education to the vitality that allows incomes in homes to then do their best work, to partnerships that make every social system more vital, to absolutely being with people at their worst and sometimes best days. The work we get to do is so personally fulfilling for me, but I just know that the end of a lifetime, looking back, we could say we were good stewards of our time doing this work, because we made a real difference where it mattered most. And that's why I ended up in healthcare.
Boy, Brian, I think that's that dash in the middle of the two dates, right? And you want that dash to matter. So well said. Jesse, how about you?
I have to say, my story is nowhere near as profound as everyone else's.
I bet it is.
I stumbled into healthcare. I was working as a security guard at Carolina. I have to specify, University of South Carolina, which is where I did my undergraduate work. My dad was in the Army there at the base, and so I was working as a security guard and drove by an Eckerd drugstore, and they had a sign that said "Help Wanted," and I walked into the Eckerd drugstore, and the rest is history. The Army later solidified that by making me a healthcare administrator in the Army as a medical service corps officer. And of course, I did that for the next 20 years and retired at Fort Bragg. But I got started as a pharmacy tech at Eckerd Drugs. Actually, we were called drug clerks back then, so we weren't really even called pharmacy techs. We're called drug clerks at Eckerd Drugs. So,
you know, there's such a thing here, though. I think as I hear your stories and I think about mine, you know, 32 years ago, I entered into nursing. But before that, I was a certified nursing assistant when I was in high school. Went through dual enrollment to get my CNA and figure out if this nursing thing was what I wanted to do. And once I caught the feeling and sense of helping another person, I was hooked. And for me, it was about going home every day, Linda, like your story, that you know, I just knew I connected and I made a difference. And like Kathy, you know, I had a passion for nursing, but then I found myself in a different role in leadership, and I was trying to figure out, how do I connect to the community, because it was the person that I went to church with that I wanted to do something that helped their family. And that's that dash in the middle of those two dates. And I think, Jesse, all of us have sort of found ourselves on paths and walking through doors that were unexpected, where we said, what? And then we turn around and figure out later, boy, that took us to a new place. I know for me, I wanted to end up back near my home community. That's why I serve where I serve now. I feel like they invested so much in me as a child and a teen growing up in college, and I wanted to be back in Western North Carolina helping make a difference for the people who helped me. And you know, my story is really touching, because a year ago, the hospital that I lead saved my dad's life, and he had a massive heart attack. They identified it. Probably if he was somewhere else with the symptoms and the results, he would have been delayed, not had the care that he had here. He ended up triple bypass with no previous symptoms. And today he's walking 4 miles a day at 82, living his best life. And it doesn't get any better than that when you are leading organizations that do save people's lives, and sometimes the lives of your own family. And it matters. So I hope that the folks that have joined us today have heard the passion and care and innovation that is in rural healthcare. Our future is bright. I think while we face headwinds and challenges, there's so many wonderful things going on in rural healthcare across North Carolina. And I hope you felt that today from our panelists and seeing their innovation and excitement as they work to advance healthcare in their communities. That is all the time that we have today. I do want to say a final thank you to each of our panelists, Kathy Bailey, President and CEO at UNC Health Blue Ridge, Brian Floyd, the President of ECU Health Medical Center and the COO at ECU Health, Linda Stanley, President and CEO at Dosher Memorial Hospital, and Jesse Tucker, President and CEO UNC Health Wayne. You've been so generous with your time, and we really appreciate you allowing us this opportunity to get to know you and your systems better. I'd also like to thank all of you in our audience today. And if your question was not addressed, we weren't able to get to all of the questions from the audience, we'd still love to hear from you. If the question wasn't addressed, please send an email to communications@ncha.org. Today's conversation has been recorded and it will be available for viewing or listening at nc.healthcare.org. So please do share that with your community. My name is Michelle Fortune. We thank you again for attending, and please join us again next time. Have a great afternoon.